Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Kate Mihevik-Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Hi, everyone. Welcome to Interdisciplinary Case Miles. We are so excited you're here, and we are really looking forward to this conversation. Hi, Sarah. Hi, Kelsey.
Hi, Kate.
We all were together recently, which was super fun because we don't get together very often in person. So this is kind of our first time back together on the mic, I guess. So our case today is going to be another hamstring case. And we know that our first case that we put out was a hamstring case, but there's so many different ways hamstrings can present and so many different ways that they show up. So we thought that this was a really cool case and something that we would bring to you regardless of the fact that we already did hamstring. Plus, we're going to run out of body parts if we don't start going back and forth, right? So this case is a 40-year-old male athlete, and he had some hamstring injury, like kind of chronic hamstring issue for a while, but he was managing it, no big deal. It wasn't really interrupting his daily life or his running and training. He's an age group runner, so he does really well in terms of local races. He works out on his track locally with a club, and he was, unfortunately, it was icy out, and he was out leaving his home, going to the grocery store, and he slipped on the ice. And when he did that, he had a sharp pain in his hamstring, and that kind of chronic hamstring issue became an acute-on-chronic issue. So I'm going to let Sarah take the beginning of this case and kind of go ahead and talk through it.
So for this case, this is someone coming in that they've been dealing with this hamstring, more acute-on-chronic type pain for around about 6 months or so. Thought they could kind of kick it, and it just hasn't gotten better. And usually kind of that first 6-week period, I think, can be reasonable to see, how does this kind of pan out? Does it calm down, go away, we go on, or are things going to continue to nag? So I would love to see them definitely sooner than 6 months. But at this point, one of the first things that I do here, certainly I have a concern that they could have a high hamstring injury, so closer to that sit bone. But I always want to rule out if there's any nerve involvement. So certainly in that slip, he could have also injured a disc in his back. And so asking some questions about numbness, tingling, weakness, those types of things are really imperative as well. And then kind of finagling on their physical exam, is this more neural tension and nerve pain? Is there back pain? Is the back pain directly related, or is it more kind of secondary to their hamstring pain? But if we've really honed in that this hamstring, this high hamstring is really what's bothering him, then I want to find out, is there a tear there, which certainly it's a good mechanism for it, especially if they've had some kind of tendinopathy or chronic tendon changes over time and some degeneration. That spot makes them much more likely to have a partial tear there, which can happen just over time, or it could happen with an acute event like a slip and fall, or going acceleration to sprinting or deceleration. So at that point, if they haven't already done physical therapy, that's usually the place that I'm gonna start and send to someone like Kate. If they have, and sometimes at this point they've been through a couple of rounds of some physical therapy and are really frustrated not being able to get back to what they want to do, then I may lay out some of the additional procedure options that we have to help heal this thing. And usually I give them a few months before we jump into any kind of procedures for this. But if we are at the point of considering procedures, then we can talk about things like platelet-rich plasma or even percutaneous tenotomy procedures, both of which I think have a really similar approach in terms of helping stimulate a healing process. So these are both regenerative medicine techniques, and essentially we're trying to increase inflammation, which we liken to that healing response, and actually having the body kind of hone in on this area and deliver some healing responses to it. So platelet-rich plasma, if someone has a significant tear in that tendon, usually that's what I'm going to recommend recommend over the percutaneous tenotomy. So the tenotomy procedure is a special device. There's a few of them out there, and essentially you're debriding the tissue and poking some holes into the tissue to cause some microbleeding. If we already have a big tear there, we want to be careful because could we potentially stimulate a bigger tear? So if this was a moderate or high grade tear, platelet-rich plasma, which we just put the blood products into that site to stimulate a healing process, is usually what we would do over the tenotomy. If they have no tear there, then or a small tear, a tenotomy would be a reasonable option. There's a couple of things that we think about with the PRP. We're trying to stimulate a healing response in something that's become chronic, but then we have a lot of other factors afterwards that we can talk about, and certainly Kate and Kelsey are going to help me with this here. So initially, we're going to stimulate some healing. We do know that a higher platelet concentration is going to stimulate more healing in that tendon. However, it's also going to stimulate more soreness and pain. So there are a lot of different ways to manage post-procedure protocols for PRP. So I'll tell you a little bit about what I typically do and kind of where things have gone. And then certainly I'd love to hear how Kate is managing these from the PT side in her practice. But generally, I'm having them shut down activity to some extent to protect that tendon for the first period, which usually is around about a week. So it depends on how sore they are. I'll have them protect the tendon if they're having pain with walking. So a couple of days on crutches if needed. Doesn't have to be super strict. But certainly if they're painful, I want them to protect that area, then gradually kind of build their walking tolerance. And then I'd have them go see Kate. And usually I have them give 1 to 2 weeks before I'm getting them back into physical therapy. But also that tends to be structured based on how physical therapy is paid. So if you're trying to minimize number of sessions, people are waiting longer. But if we've got the opportunity, such as with our professional runners team, they'll probably get in to see Kate right away. And there's a lot of things that she can do to help facilitate that healing process. So I've talked enough, but I could certainly, if there's anything else you think I should add, Kate, but I'm going to pass it over to you. So we've done the PRP injection to the proximal hamstring or high hamstring. And then what would you do next, Kate?
Yeah, I actually want to ask you one question, though, because this has come up on my table before. And sometimes, and we've talked about this on the podcast, I'll get the person first before I would send to you. And if they weren't sure if they had a tear or not, how would we identify it? Would it be ultrasound? Sometimes I can feel it, an actual divot in the hamstring itself. But how would you decide whether that was an actual tear or not?
Yeah, so I generally do it two ways. Usually I'm doing more workup before this time. So there's a good chance I've gotten x-rays of the hips. I've gotten a low back x-ray at minimum. And then oftentimes I'm getting an MRI of the hips because even though an x-ray may not show arthritis, an MRI is going to show a little bit more in terms of if there's any cartilage injury. And the reason that's important is because hip joint pain oftentimes can mimic high hamstring pain. And so I'm trying to rule out if there's any arthritis component to it. It'll give me some visual of the hamstring on the MRI, but tendons honestly are generally better visualized under ultrasound. So I will generally also put an ultrasound on them in the clinic and take a look at it. Plus we could do some real time work and I can show the patient what we're looking at as well.
Yeah, that's great because that's something that a lot of my patients ask. And I actually am thinking not this case, but another case. I had a gentleman who was water skiing. He was a runner and he fell, got pulled and tugged, and he tore his hamstring and it went without people realizing what it was. But when I felt it, it was this huge divot and I was like, oh my God, and had to send right away. But that was just something that came to my mind as you were talking. So thank you.
Absolutely.
Okay, so for this patient, we had talked about this. This is a stiff guy, and I always like to bring it up. I know we kind of joke about it sometimes. We talk about like, oh, some runners are pretty stiff because they're not doing mobility or they're not stretching, or maybe they're just running all the time and they didn't know they needed to do all these things, especially sometimes when it's in this age group. And I often send them to like stiff guy yoga just to get them moving. It's one of my favorite yoga classes, actually. But anyway, so because this athlete is on the stiffer side, that changes how they might be moving and loading the tendon and challenging the muscle and the nerve and even the low back, right? So when I'm getting this patient in, so in my practice, a lot of times we see patients who have had PRP the same day. There's a protocol that we use where if they have PRP with certain physicians in the area, they'll come in, we'll do it that day. And the reason, I'm sorry, I said PRP. I said they'll come in that day so that we can do BFR, which is blood flow restriction training. So blood flow restriction training is something that we use like a cuff for, so like a blood pressure cuff, and you put it high up on the leg, almost as high up as you can go, and it's pretty snug, like you just wrap it around. And then we make sure that it is, what we'll do is calibrate it to make sure that we know how much blood flow is being restricted. So it can be anywhere from like 60 to 80%. I usually depend on the comfort of the patient. So sometimes it is around 70% that will restrict that blood flow. And then the reason that we do that is because when you're restricting the blood flow, what you're actually restricting is the venous flow, and it creates this hypoxic environment. And then there's an accumulation of lactate, and then that also drives the growth hormone in that area, which is one of those healing hormones. And then the other thing that happens is that the type 1 muscle fibers actually begin to fatigue out. And when the type 1 muscle fibers start to fatigue out, then the type 2, which is your fast twitch muscles, they start to kind of kick in. So this happens, and then there's more muscle protein synthesis, and then also there's increased capillary density. So there's a lot of different things that happen when you use blood flow restriction. And it's a really good environment after they've just had PRP, where we're really trying to get this healing response. And the other thing about this that is really lovely is that you're not actually challenging the tendon. What you're doing is you're basically creating what a 1 rep max workout would look like by doing very simple exercises that are not going to stress the tendon. And we're really focusing on maintaining muscle strength. And so our protocol is you do 30 sets, then you rest 30 seconds. Then you do 15 sets, you rest 30 seconds. 15 sets, rest 30 seconds. 15 more sets, rest 30 seconds. So it's 30, 15, 15, 15. And we do 3 exercises, and they could be anything. So for a hamstring, this is crazy, but it might be you're laying on your back and you're doing a leg lift, which is not an exercise that I typically do, but because we're just trying to get movement. We might have them do maybe a gentle hamstring curl, or we might have them do a squat, or we might even have them do something for their glute. So it doesn't have to be a specific hamstring exercise, even though that's the muscle that we're trying to work, because what's happening is all of this stuff that's happening in the background is actually going to flush the system and make it easier to heal. So that's one of the main things that we do when we have someone that's come for PRP. And there's so much more I could talk about when it comes to hamstring, and we can kind of circle back about that, but I would love to hear where Kelsey is on this.
Yeah, absolutely. And then just out of curiosity, because I know it's the number one question that this gentleman's going to ask, is what would be like the earliest that you would start a return to run program?
Well, I would want to know what Sara's protocol is in terms of how she wants to load that tendon. So typically when we have BFR, so PRP and BFR, I'm getting like jumbled up in my words today. I'm so sorry, guys, because we're doing both. But for a return to run program, it would depend on what she told me in terms of timeline, and then how he's responding and how he's feeling. We're obviously going to try to get him back as soon as possible because we probably can based on what we're doing. And again, with a hamstring injury, you want to load it. But there is a certain timeline that, like Sara said, she takes at least a week off. So BFR is not really loading it that much. So it's still safe in that first week. So we'll start doing harder things in the second week.
Okay. I've seen protocols all over, or protocols might be a strong word. I've seen different runners take different amount of time off after hamstring PRP, like anywhere from like 3 days to 8 weeks. Like I've seen a lot of variation.
I think it's all still really changing. I mean, the literature and the protocols are also heterogeneous, and even the things that we're using in terms of the concentration of the platelets and, our is the person doing the procedure, are they doing some level of needle tenotomy and hooking some holes in the tendon, disrupting the tendon? Generally, if you're disrupting the tendon, that's when I'm much more careful to protect the tendon
Yeah.
for that initial period of time. But if you're just putting some PRP in the space where there was a tear, then that's a little bit different. But in any case, usually the tendons are getting pretty aggravated. So I think that pain can generally be a pretty good indicator in terms of progression. But the way I've generally done for both joints and for tendons is somewhere between 4 to 6 weeks for that progression to happen. But I think it's different for everyone. It depends on how bad it is, and it depends on how many platelets are going in, and how fit they were beforehand, how much PT they've been doing. I mean, I think it's really variable. I agree. I mean, I think I've had some people get back to running within 3 weeks, but generally we're looking more to 4 to 6 weeks because this is something usually that has plagued them for quite some time. And I think this is kind of similar in this scenario where they've already had some off and on pain, and then they had an acute insult as well that flared it up even further. So I think the shortest answer is it depends, and we're still trying to figure it out, right? I mean, our PRP literature is still all over the place. We have literature saying that it's great and does wonderful things, and we have literature saying it's comparable to steroid, and literature saying it does nothing. So it's really variable in terms of it. But again, what people are doing around in terms of their protocol and how many platelets are going in and how they're doing the procedure is just widely variable at this point.
Well, and I think that people, if they do decide to get the PRP injection, I always say you're probably going to be in more pain right afterwards. So not everyone expects that. And it's really important to talk about. And I know you talk about that with your patients, Sara, but also at that 6 week mark, you could still have pain. And so you might actually be okay for the first 4 or 5 weeks. But then at that 6 week mark, that is always when people spike in pain. Every time in our clinic, it's like a 6 week mark. I tell them on the first day, they don't remember. And then on 6 week, we're like, okay, well, this is normal. You always feel a little worse right now, right before you kind of get over the edge. And so I think that that's also really important for people to understand. It's not a quick fix. It does make you have some downtime. It's pretty uncomfortable, but it can help if you're doing the PRP with the right environment. I wouldn't, and this is something that we were talking about before, but I definitely wouldn't do PRP or physical therapy. Of course, I'm a little bit partial because I'm a physical therapist, but I would do PRP and physical therapy and BFR if you can.
Yeah, and I think you bring up a really good point. Is I've had folks come into the office and want to get PRP today, and I'm like, oh no, we planned for this. It's almost like a surgical date because we're doing things beforehand, we're doing things during and after. We need a driver. A lot of different things that we want to consider for the actual day. And so I tell people, no, we're going to talk about it. We're going to find an optimal time because you're exactly right. Their pain is definitely going to feel worse. And generally, I always tell them like, tendons are a little different, but and tend to be more sore. And exactly what you said, having spikes. I think especially as you start getting more active, it feels better. Then you get more active, and then it gets sore again. But usually that first few weeks is soreness related to the injection and irritation of everything, and kind of stimulating that inflammatory response. Pain levels usually start to come back down, and then really don't start seeing changes until 6 to 8 weeks. Again, kind of depending on where that protocol is for physical therapy. So yes, it's very different. Whereas the steroid may make you feel better for a couple of days or even a couple of months, but ultimately we're not stimulating a healing change. So it's an investment for sure. I mean, it's not for everyone. And I want to be very careful, when we're picking and choosing what's going to be the most helpful. The percutaneous tenotomy procedure, or debriding some of the tissue, people usually feel better a little bit more quickly. But again, not every tendon is going to be the best option for it. And actually, while I'm along this lines, just also want to put in a plug that platelet-rich plasma. So we take the patient's blood, we draw blood from the arm, just like a venous blood draw, spin it down, take a layer rich in platelets and growth factors, and inject it straight back into the site of interest. And sometimes there are contraindications. So if someone's on a blood thinner and they can't come off the blood thinner, if they're on aspirin and they're not allowed to come off that for any period of time, if they've had cancer is a relative contraindication, but any kind of active cancer would be absolute contraindication. So there's a lot of things that we keep in mind. There's question too, if folks have autoimmune or chronic inflammatory disorders, how valuable that PRP is, and we just don't know the answer to that yet. So certainly kind of keeping all those things in mind. The young, healthy blood is generally going to be more chock full of helpful things than older blood, or someone who's got chronic disorders, inflammatory concerns. So there's also, the the PRP product is only as good as the blood product that it's coming from as well. So we also want to keep that in mind, and I always have that conversation with folks as well. Generally, the risk with it is relatively low. It's an out-of-pocket expense. It's not covered by insurance, and we're going to make you sore before it gets better. But if it doesn't work, generally it just doesn't work. So I think it comes with kind of similar risk that any other type of musculoskeletal injection we might do comes with. So relatively low risk and can be worth it. But usually the big kicker is that pain going up and having to manage that and figure out good timing for that. So,
well, and the other piece is just getting the injection, and even getting the injection and doing BFR is not just the answer too, because remember this guy that we're talking about, like every runner that we probably have ever seen in our entire life has other things going on, whether it's a mobility issue, neural mobility issue, run gait, if they're stiff, how they're moving. And I'm thinking about the age of this person is a 48-year-old male. And as we get older, not necessarily 48, but if we're looking a little bit older, our gait even starts to shorten naturally. So there are different gait changes that could be occurring that could also be impacting how this tendon is in terms of its health on a regular basis. And so we still have to address all of those things on top of it. Kelsey?
Yeah, I heard both of you say two things. I should just have both of you present cases before it's my turn, because I come up with better ideas. But I heard, Kate, you talk about the environment matters, the environment that the athletes and the environment of their body. And then, Sara, I heard you talk about the blood. And so both of those are mediated by our nutrition. Our nutrition has a big role in both of those. And just like a trend of being an athlete, a big thing that I see is athletes maybe thinking about it like they're going to get PRP and it's passive. But I think about, more so that it stimulates this biological cascade, but then it's kind of the environment and the quality of the blood and everything that can help further support and make it a two-part, process. And certainly like the blood, and like the response after the PRP is dependent on like the energy availability, the macronutrients, especially protein, and the micronutrients. And then also like what was that environment like before the injection too. And so I think that, in terms of thinking about some of the athletes that I know personally that have gotten PRP, and I'm like, well, I know they have like low ferritin and that kind of thing. So energy availability probably wasn't the best. But yeah, just to name a few, I got some practice with this a few months ago with my husband. He didn't get PRP, but he got another regenerative procedure. And so I got to practice this with him. And the things that we focused on, like, of course, in the first few weeks, we didn't do anything like herbal wise that was anti-inflammatory because we want the PRP to do its thing. But then after a certain amount of time, I actually did talk to his, the person doing the procedure, could we do things like omega-3s and turmeric just to kind of support, some of that inflammatory response and keeping the inflammation low so that the body can do its thing. But again, we don't want to stop inflammation. I'm sure Sara could talk more about that. So waiting a good period of time. I started him with those kinds of things a few weeks after his procedure. And then definitely initially increasing protein intake. Normally the calculation that I use is 2 grams per kilogram of body weight. And then, it's hard to out supplement this, but just to name a few micronutrients that are important, I think of iron for sure, which I already talked about, really important for oxygen delivery and collagen synthesis. Zinc for sure, it has a big part in fibroblast support and proliferation. That's found in a lot of protein foods conveniently. So just boosting your protein intake, you can kind of kill 2 birds with 1 stone. And then copper, vitamin C, those all have big roles in tendon and tissue repair. And then as Kate was talking about BFR, I've never fully understood it, but as she's talking about different like muscle protein synthesis and type 1 and type 2 fiber types, since we're like making a switch from type 1 to type 2, I don't know how long you anticipate that the type 2 fibers are going to be working, but that's definitely a more glycogen depleting fiber type relative to the type 1 fibers, which is more of a slow oxidative it's using more of like the fat as a substrate. And so I don't know if that means specifically increasing carbs before that BFR session or how long that process kind of takes in the process. But I thought that was cool when you were talking about the different muscle fiber types and then trying to accomplish muscle protein synthesis, which is, after that, protein and carbs together help further support the process of muscle protein synthesis.
That's really cool.
Yeah.
So they should be snacking before they're doing their BFR. So they should go do PRP, grab a snack with enough carbohydrates and protein, and then come over to PT and do the BFR, it sounds like.
Yeah.
Yeah, that's really cool. And the BFR sessions are about 30 minutes because you have to do like 3 exercises, so many reps. And also people's legs do turn a little blue at first or like a grayish. It's no big deal. It's always a little scary, like the first time you do it, and it's uncomfortable. So that's why like you change the occlusion rate. Like I usually start them, at like, 70-ish, and then I might go to 80 at some point when they're feeling comfortable in another session. But, we would typically do that a few times a week in the beginning for the first, 2, 3, 4 weeks usually.
Yeah, I never put it together that, 30 minutes of it, which you said when you were talking, I just forgot that 30 minutes of it is like a 30-minute hard track workout you would definitely fuel up for.
Oh, we both learned something. All 3 of us learned something
so cool.
there. What were you going to say, Sarah?
And Kate, are there folks that you would not recommend BFR in?
I mean, there's definitely people that we wouldn't do it in, right? So it's kind of the same thing as PRP, right? The same recommendations would go with that. And then also, there are some people that just aren't going to like it and not going to respond well because it's of the discomfort in it. So yeah, there's definitely a group of people that I wouldn't do it in. It would be the same kind of guidelines as PRP. Yeah.
One more thing that I was going to mention too, Kate, is you mentioned the stiffness and the link to the chronic tendinopathy. And I was thinking of all kind of the intricacies of how everything was related. Like, so they're stiff, and so they develop the chronic tendinopathy, they've been off and on, and then they slip, and potentially they're at higher risk of having an injury in that tendon because they're stiff when they slip. And then how all that kind of interplays. And so, we're treating like mini layers, right? So there's kind of a bigger picture that we're treating, but then we start with the hamstrings. That's where they're having most of the stuff, and we had the most acute injury there. So we can give them a little boost with the treatment and then kind of set them off to start their trajectory. Because a lot of times patients are like, well, should I start physical therapy now if we're going to do PRP and then shut it down again and then start it again? And so kind of prepping for that process. But do you have further comments on that?
Like I would say, I would want them the same day as PRP, and then I would keep them because I would do BFR, but also when it comes to the hamstring and when it comes to someone who's super stiff, I will be treating, as everyone knows now, I say this every single podcast, I will be treating their hips, I will be treating their lumbar spine, and I will definitely be treating this person's thoracic spine and cervical spine because of the increased neural tension and just how that entire spine is moving. So I'm going to try and give them as much mobility in other places around the hamstring so that they're successful with the hamstring. I don't even need to touch it in the beginning. I really don't, because then I could also be looking at their dorsiflexion. How is the leg actually moving on the pelvis? All of that. So we'll be treating every bit of that. And then, like I said, we're not really going to be stressing that tendon right away. And that's where we're going to be using that BFR. But then we're going to be doing manual therapy because, this is what I was thinking about while we were talking about the stiff hamstring. I immediately started thinking about like the feel of the fascia that next to the nerve in the hamstring. Like I'm literally imagining how gritty it feels in my mind. So I would definitely be doing like some soft tissue and manual therapy around that area leading up to like the top of the proximal hamstring. I'd be checking obturator and turnus. So there's just a lot of things that we could be doing. I definitely want those people early. I don't want them to go. I want PT day of. And if I can't have day of, I want it the next day or within a couple days. And I do think that there is this misconception that like PRP and done, it's not going to like you're going to get better results with PRP if you actually do all the other things because the other issues don't go away. when you have PRP, the reason you got there in the first place, the PRP is just going to help with the healing process, but it's not going to change mechanics, and it's not going to change the fact that your fascia and that nerve is so stuck, and it's not going to change that you can't bend over and touch your toes. Not that you have to bend over and touch your toes as a runner, but a lot of runners don't have that mobility and would benefit from more.
And you need to be able to stimulate those fibers to reorganize. So our gold standard for treatment of tendinopathy is eccentric strengthening, right? And we still have to get back to that. But I love the fact that you mentioned, so we're talking about comprehensive and holistic care here, but you're also talking about the holistic care of the entire musculoskeletal system. And I think that's so often forgotten. I've had folks who have done PT for their hamstring and all they've done is hamstring. And it's so important to get the glutes turning on and to look at the entire spine and to look at your mechanics overall. And I think it's so important. I love hearing when you're talking about that, Kate.
Well, I can't believe I didn't say eccentrics because that's literally one of the first things that we do. Thank you for saying that, Sara. It's almost like I assume that it's happening, so I don't even talk about the most obvious. Yes, we want to do eccentrics for tendon and also sprinting, which we talked about before, but that's like moment we don't need to that's a little bit later. But you have to load a tendon for it to get better. That's the bottom line. Cool. All right, ladies. So I think this one, we should definitely wrap it up. It's interesting. I feel like I could talk about this one forever. It doesn't even feel like the other hamstring discussion that we had, which is really cool. So why don't we start with you, Kelsey, actually? What would you like to kind of close this out with? What are like the 2 or 3 things that you want everyone to take away from this discussion from your perspective?
Yeah, I think that, just asking yourself if you think that you have, before you decide to do PRP, or I guess like just asking yourself, is there a way that you can ensure that you have a good environment to support it? And so that can look like getting labs or just knowing lab values beforehand and looking specifically at I'm talking about the nutrition end of it, the ferritins and the CBCs and stuff like that. But also you kind of know too, like what has your nutritional habits been like to support something like that? So it makes the investment more worthwhile.
So you wouldn't just eat popcorners and peanut butter cups?
I don't want to hear it.
All right. What about you, Sara?
Yeah, so PRP and the tenotomy procedures, they're really just not first line, and our evidence is still a little bit all over the place, but I think the risk is low and in the right patient who's been worked up appropriately, and we've tried some things and it's still nagging them, or they're trying to throw the whole kitchen sink at them if they've got kind of a shortened timeline for a race or something of that nature. So I think it's a good adjunct, but ultimately, like you said, Kate, we've got to have the eccentric strengthening. I usually put people through several months of therapy. So we want to really try the basics before we get to that. I usually do not start immediately with those procedures.
Great. And my takeaways are, if you have some kind of like slip or fall or tug, make sure you get that checked out to make sure if that hamstring or whatever the muscle tendon junction is if it's actually a tear or not, because that is important in terms of how we would treat it. Always know what you're treating is the biggest thing we say. And then the second piece is PRP is it doesn't get to be alone. Like you have to have PT with it. You have to do other things with it so that it can do its job. So it's not one or the other, it's both. And the reason that you probably had the injury in the first place was because there are other things happening in the environment, whether it's, again, because you're super stiff or something going on in your pelvis or your run gait or something like that. So
yeah, I think sometimes I've had a couple patients recently that when I told them they weren't a candidate for PRP, they felt like, oh, like I'm missing the $1 million ticket. And the answer is, there's one thing we can't do. But oftentimes there's so much other stuff that we can do. So I like folks to know that just because you can't do PRP doesn't mean like you're missing the magical treatment.
That's great. All right. Well, thank you guys for joining us again. And we just want to remind you that if you like this podcast, please follow it. Please give it a good rating and also pass along to your friends. Pass it along to coaches, other healthcare providers, other runners, because that's how we really get the word out. And we are just really trying to educate people on what they can do to help themselves. And other providers, just give them other ideas. So we hope you enjoyed this. And thanks for joining us. We will talk to you soon.